It's my pleasure to open up the program for our second series of community conversations on cancer. Um, this is a special occasion for us to bring our scientists to our community and our community to our science. The two can go together, and we want you to take a moment and just take it all in, to listen intently, to um, to share this information with others as you receive it. I even encourage you to take a few notes if you feel to do so. The purpose of this series is connecting our community with our science and our science with our community. These conversations are a space to share knowledge and to build strong connections between our researchers, our providers, and people we serve. If you are excited about being a part of this event, then we ask you to be a part of our COE. We have a table there with information where you can get involved. We are proud to partner with the main library here, with Brian Vance, Andrea Thompson, and the whole staff of the main library. They do such a good job to set up for us. If you don't mind, will you give them a hand? We also would like to recognize our RAC partners. The RAC is our Research Advocacy Consortium. The American Cancer Society, who has a table in the back, and most of our vendors are here. The American Cancer Society, the Blood Cancer United, Gilda's Club of Metro Detroit, the National Council of Negro Women, Detroit Section, the Pink Fund, Pro Literacy Detroit, Sisters Network of Metropolitan Detroit Chapter, Western Wayne Family Health Center, Detroit Parent Network, and Healthy Black Elders. We are also grateful for the Global LT for providing translation services both in Arabic and Spanish. If you're joining online, you can select your preferred language by clicking the interpretation option at the bottom of your Zoom screen. We have a few housekeeping notes. For those, for our audience online, if you have questions during the presentation, please use the Q&A feature in Zoom. For those attending in person, please kindly hold your questions until the end of the session, and we'll have a Q&A session at the end of the presentation. Please know that we are recording this event to help us share and expand the impact of this conversation. For those of you in person, the restrooms are out this back door and to your right. Finally, I would like to acknowledge our speaker, Dr. Tony Shields, MD, for joining us tonight. You can give him a hand now. Our moderators, Kenyatta Cole, Vera Bailey, and Craig Cook, who will be guiding this important conversation. And now I'm going to turn the program over to our moderators to introduce themselves and get us started. Moderators?
Good evening, guests. I'm Craig Cook. A little history about my background and what brought me here today. My grandmother was diagnosed with breast cancer. Okay, cool. Good evening, guests. I'm Craig Cook. A little history about my background, which brought me here today. My grandmother was diagnosed with breast cancer at Harper Hospital in 1974, which began my interest in cancer, and I began studying it when I was an undergrad at Wayne State University. In the subsequent years, all four of my grandparents died from cancer. A very, very good friend, and my father passed away from cancer. At that time, I knew that when I retired, I would dedicate the rest of my life to educating others educating others on the need for early detection and reducing the number of cases in the community. It's been both an honor and a privilege to stand here today as a volunteer and advocate for Karmanos Cancer Institute, my dream job for the past 12 years. Thank you very much.
Good evening, everyone. My name is Kenyatta Cole, and I am the president of the National Council of Negro Women Detroit section. It is an honor and a privilege to be here today. NCNW Detroit section serves as a partner, a RAC partner to the Karmanos Cancer Institute. So that is something we have started in the last 6 to 7 years, and it's been a pleasure and an honor to be a part of that. We are here today because NCNW focuses on core 4 priorities, and one of them being health equity. And so for us, colorectal cancer is something that our community needs to know about and understand and be more aware because it's a more prevalence for us. So again, it is my honor and privilege to be here, and I am going to introduce our next moderator, Vera Bailey.
Good evening. My name is Vera Bailey, and I'm pleased to be here tonight. I am a colon cancer survivor, and I was lucky enough in 2016, I joined the Cancer Action Council. I had been a member for maybe like 2 months, and I found out that I had colon cancer. The way I found out was because I went and had a colonoscopy done. I want to thank all of the members of the Cancer Action Council because they stood behind me 100%. And without them, I don't know what I would have did. I tried to hide it from them, but those women. And as time went on, I was lucky enough that they caught it in time so I didn't have to have chemotherapy or anything like that. So prayer works. And one other thing is that really, really, really make me want to be involved in all of this is because there are so many different cancers, and you might be scared when a doctor calls and says, come in, I need this or I need that. Go. And you don't know how many times I wanted to cancel appointments. But I said, do you want to live or not? And other members of my family has died from cancer. My sister died from colon cancer. My brother died from prostate cancer, and my mother died from lung cancer. So all I want to say is thank everyone, for being so supportive, and my little CAC members that spread it around. I want to thank y'all so much. And Vonzel, you got me involved, and I appreciate that. Okay. Now, before we dive into today's topics, let us start with a few quick questions to see what we already know or think we know about this subject. Don't worry, this is not graded. It is just a way for us to reflect on our current understanding and get us thinking. This will help us connect what we are about to learn with what we already understand. For those of you joining us in person, you should have received a packet when you arrived. There is a pink sheet of paper labeled Pre-Knowledge Questions on top with 3 short questions. Please take a moment now to complete this sheet. Upon completion, please tear off this sheet and hand it to one of our COE team members who will be coming around to collect them. For our participating joining via Zoom. A poll will be launching on your screen in just a moment with the same 3 questions. Please take a minute to answer them using your device. Thank you all for your participation. Are we ready? I know that I have hemorrhoids and occasionally notice a small amount of blood in my stool. Because hemorrhoids can cause bleeding, I do not need to mention this to my doctor or consider evaluation such as colonoscopy. Is that true, false, or not sure? It's, it's your sheets. My colon cancer was removed surgically, but had spread to a few nearby lymph nodes. With appropriate treatment, which may include a course of chemotherapy, there is still a good chance that the cancer will never come back. Y'all good, y'all good. Which cancer is estimated to cause the second highest number of cancer deaths overall in both women and men in the United States in 2026? Pancreatic cancer, colorectal cancer, lung cancer, and liver and binary cancer. I want to thank you all so much. And I could tell you're knowledgeable because y'all couldn't wait to holler out those answers. So thank you so much.
I would like to introduce our speaker for this evening. Dr. Shields is an oncologist with an MD from Harvard and a PhD in biology from MIT, where he studied viruses which cause cancer. Dr. Shields completed his residency in internal medicine and fellowship in oncology at the University of Washington School of Medicine and the Fred Hutchinson Cancer Research Center. He is a professor of oncology at Wayne State University, where he works on the development of therapeutics and new imaging methods. He is a medical oncologist at the Barbara Ann Karmanos Cancer Institute in Detroit, where he is Associate Center Director for Clinical Sciences and holds the Charles Martin Endowed Chair for Cancer Research. Since 1996, he has participated in more than 500 cancer research trials as the principal investigator or as a co-investigator. Dr. Shields is an expert in gastrointestinal cancer, particularly colorectal cancer. He has published over 200 articles with over 60 articles on colorectal cancer. He was the national co-chair for the SWOG, formerly Southwest Oncology Group, colon study as part of the IDEA collaboration, which has shown successful adjuvant treatment with chemotherapy for 3 months versus 6 months in stage 3 colon cancer. He is also this study involved over 13,000 patients across a dozen countries. He is also currently working on the personalization of cancer treatment using genomic testing. Dr. Shields is leading research studies on Therabionic, a non-invasive, FDA-approved treatment that uses low-level radiofrequency energy delivered through a portable device to help slow growth in patients with liver, pancreatic, and other cancers. He is also developing studies using theranostic agents, a newer approach to cancer care. These treatments involve giving patients medication through an IV that travels directly to their tumors and delivers a small targeted dose of radiation. This approach is designed to target cancer cells while limiting its impact on healthy tissue. I would like to introduce you this evening, Dr. Anthony Shields.
Thank you very, very much. I'm very happy to be here today and talk about colon cancer and its importance in the community and how we can screen for it, how we treat it, and how we cure it. It's something that's come a long way, as I'll show you, over the previous decades. As you heard, I'm a medical oncologist. I was born and raised in the Detroit area, actually born in Highland Park. I drive by the hospital every day coming down here. The Highland Park General Hospital is where I was born. And my mother was born at Harper Hospital, for that matter. So we've been around here for a while. And Craig was asking me why I went into oncology. And when I was a medical student, I was telling him the story how I saw a patient with Hodgkin's disease. And not too long before that, it was an incurable illness. Patients basically always died from that kind of lymphoma. And they had just developed some new combination with like 4 drugs to treat it. And this guy was treated with that, and his disease went away. He was a young man, and he said, I always thought I was going to die from this, but then my tumor went away. And he says, I always thought my life was going to be short. He was one of the happiest people I ever met because he lived his life like it was going to be short, but it wasn't. He knew every day was a gift. And he said, this is why, he said he started a business. He did it for a while. He went, I'm going to do something else because I'm tired of doing this and I don't know how much longer I've got on this earth. And he taught me this is how we all really need to live. So I always have to talk about disclosures. I work with dozens of different drug companies trying new therapies. None of them are really going to be presented here today, so I don't have to tell you the long list of companies and how it might affect my conflict of interest, so I have none right now for this. So what I want to talk about today is to understand the risk of colon cancer, the screening, which is essential to pick it up early, as you've just heard. If you pick it up early, you can get it right, sometimes right through the scope, or you can get some relatively simpler surgery and you don't need chemotherapy, which I'll be talking about. Adjuvant treatment is chemotherapy that we give to people that are at high risk of the cancer coming back, and we can improve the odds that it won't come back, and I'll show you that. Even when it's spread, we've improved the survival of those patients. It used to be months, and now it's many years because we can control the disease with the drugs. And we've got lots and lots of new drugs on the horizon, and that's part of clinical trials. So this just shows you some of the estimates from the American Cancer Society for this year. Lung cancer, and this is the estimates of death. Lung cancer is still the most deadly. Don't smoke. Breast cancer in women is the next, although screening clearly helps there as well. Pancreas cancer recently overtook colon cancer just because we don't have good screening and our drugs are still not nearly as good, but I treat that. And then colon cancer and rectal cancer is the third leading cause of death in women. In men, it's lung cancer, prostate cancer, and then colorectal cancer, followed by pancreatic cancer. So overall, colorectal cancer is the second leading cause of cancer death because men don't get or rarely get breast cancer and women don't get prostate cancer. Overall, there are about 159,000 cases, and about a third of those patients will die. So most of the patients that are diagnosed with colorectal cancer, we can treat and cure them of their disease. And in Michigan, there are almost about 5,000 cases and about 1,600 deaths. So it's a very prevalent cancer. It's something we all need to be aware of, and we all need to know what we can do to catch it early and prevent it. This just shows statistics. This goes back to about 1930. People didn't used to smoke very much in 1930, and those red lines are smoking. Women started smoking after World War II, and you can see those peaked. But when people stopped smoking, those numbers have gone down very nicely. Colorectal cancer, as I said, overall is the second leading cause of death. And you'll see on this that, that the colorectal cancer deaths have gone down for both men and women. And part of that's early diagnosis with colonoscopies, stool blood tests, and other things. And it's partly because we have better treatments for people with advanced or earlier stage disease to help prevent it from coming back. So that has nicely changed over the years. And as you heard earlier, cancer is not one disease, it's 100. The colorectal cancer I'll be talking about is what we call adenocarcinoma, that it starts in the glands. But there are actually a number of other cancers that can start in the colon that are much less common. GI stromal tumors, you can see lymphomas, you can see what we call carcinoid tumors. There are a whole bunch. Those are much, much less common. The ones that we care about most and that we want to diagnose early are colorectal adenocarcinomas. The way these cancers look and behave are different when you look under the microscope. And there's a range of genetic changes that can occur in these cancers. And we now routinely test for those changes. One, to see if it runs in the family, but two, it helps direct our therapy. And the best treatment is now based on a number of factors besides how it looks under the microscope, but we routinely test these cancers for the genetic changes. Colon cancer is often silent until it's too late, and that's the problem. I see patients with more advanced disease where it's spread, where I certainly treat it, I can prolong their life, but it's much harder to prevent the cancer from causing death. The symptoms can include pain in your abdomen. It can include anemia. So because these cancers often bleed, and so patients go to their doctor for one reason or another, they may be weak, they may just be a routine visit, and they check their blood counts and go, wow, you've got a really low hemoglobin or red count, and that's because you may be losing it in your stool, and then we test them for cancer. There can be changes in the stool. It can narrow because the cancer is pressing on the bowel, or there can be blood in the stool. And that can be the first sign of cancer for many people. So we now screen routinely for colon cancer. We've recently lowered the age to start routine screening at age 45, although, as you'll hear, we're talking about doing it earlier because the risk of cancer is rising earlier. We can look for blood in the stool. You don't necessarily see it. It's just really small drops of blood that we can see on a test. Also, there's a DNA test to look for genetic changes. Certainly the most definitive test is colonoscopy, and routinely it's recommended to be done every 10 years. For people with moderate risk, that is a relative with colon cancer or polyps, and polyps are little bumps that can occur in the colon that we can see on the scope. For those people, we may want to do colonoscopies earlier, sometimes starting at age 40, but there are genetic syndromes where it runs in families. We routinely test everybody with colon cancer to see if it runs in the family, and we may start screening as early as age 20 because the risk is so high in that group of people. The effectiveness of screening, the fecal blood test, and these tests you'll see, this is back in the 1990s. These tests are pretty old, but the fecal blood test lowered the mortality by about 1/3 or 40%. So they did these large, what we call randomized trials. Those are sort of the golden test for us, where half the people got screened back then, and then half didn't get screened. And those that got screened had about 1/3 or more improvement in survival, and because it was picked up very early. You can't do that ethically anymore, thankfully, because everybody should get screened. Flexible sigmoidoscopy is a short scope, not the long colonoscope, and that was shown in randomized trials to decrease the risk of dying of cancer for about 25%. So one of the things with the fecal occult blood test, they regularly will give you 3 cards to take home with a little spatula to put a sample on, like on 3 consecutive days, and then you have you mail it in or bring it in, and then they test for blood. If one of the cards is positive, it's a positive. And the reason is because these polyps and cancers can bleed intermittently. They don't have to bleed every day. And that's why we also say just one test is a positive test. And it came home to me one time. My father went in to get his screening test. They gave him the 3 cards. He took it home. He took it back to his doctor, and one was positive. And his doctor said, "Oh, only one's positive. Let's give you 3 more cards." And I went, "Dad, your son is a gastrointestinal oncologist." Guess what? Wrong answer. You need a colonoscopy. You do not need 3 more cards. The reason we give you 3 cards is they only occasionally bleed. I couldn't believe it. I was just like, you gotta be kidding me. And they did the colonoscopy. He didn't have cancer, but he had polyps, these little bumps that can turn into cancer. So you have to understand the screening colonoscopy not only picks up early cancers, as you've heard, but it actually picks up these bumps before they turn into cancer, and they can be removed right through the scope. So the colonoscopy not only picks up early cancer, it actually decreases people from getting cancer in the first place because it gets the polyps up. And when we see those polyps, we go, okay, you're going to get screened again in a year or 2 to see if there are any more that develop, and we can get those out before you need surgery, before you get even cancer. So just the thing is, if you get a fecal occult blood test and it's positive, and basically only about 10% or 9.3% are positive. So most of the time they're not. But if they're positive, it's essential that you get the follow-up. You need the colonoscopy. And 31% of the people that had the test had polyps, actually. They didn't have cancer, but they could get them out through the scope. Only about 1/3 of the patients had the recommended follow-up. So when somebody tells you you've got blood in your stool, you need to get the follow-up. You need the colonoscopy. And I've had people who've had the colonoscopy, have had the test, and they just assume, I'm going to die. It shows I have blood in my stool. Well, the incidence is only about 4% had cancer. So the risk of cancer is small. And those cancers, for the most part, are pretty early so that they can be cured. And I guess I need to take a 30-second pause while we switch interpreters, right?
Yep, interpreters online, please switch now.
Ready? And if you have rectal bleeding, if you see blood in your stool, do not assume that it is actually benign. Yes, you may have hemorrhoids, but that doesn't mean that's the only cause. It could be a cancer further up. And I can't tell you the number of my patients that I've seen over the years where they reported to their doctor that I had blood in the stool. The doctor said, you've got hemorrhoids, and they ignored it. And then 2 years later, they have advanced cancer. So don't listen to your doctor if they say, you've got hemorrhoids. Wrong answer again. If you know you've had hemorrhoids and you did a scope last year and you still have intermittent bleeding, that's not that, you've gotten the appropriate test. But if you haven't had a colonoscopy, and that's really, it's true for people in their 40s and 50s, but also now in their 30s and even 20s, you need to get the appropriate test. So please, and it used to be actually insurance companies wouldn't pay for it if somebody reported blood in the stool. But a positive stool test was positive, and they would pay for a colonoscopy. I said, well, that is really stupid. So I would tell the patients, next time you bleed, put a little bit on the card and bring it in, and then you'll be positive, and then they'll pay for it. So, but, a lot of the patients who had bleeding, it may not be hemorrhoids. They could have polyps, as I said, these little bumps. They could have inflammatory bowel disease. Again, most of the people don't have cancer, but a few percent do. And in this case, it could be life-saving to get this. So in increasingly we're seeing colon cancer in patients under age 50. It's surprising. I've got patients in their 20s and 30s and 40s. And as I said, a lot of times these people have gone to their doctor and said, I have blood, and the doctor sort of poo-poos it. Well, no, you can't do that. The risk is just as high. So even in patients under age 40, they need to get the testing done appropriately because of this. Yeah, we're seeing a lot more of the younger patients getting cancer. I should also point out African Americans have a higher incidence, as was mentioned, of colorectal cancer and a higher death rate. Some of that's because there's a slightly lower risk, they take less advantage or less ability to get the screening done. So it's important to mention to your doctors that you want the screening. They often have less follow-up when they get the screening and they show abnormalities and delay treatment. So there are a number of reasons there's a higher death rate in African Americans, but you being your own advocate can help overcome some of these barriers. So colorectal cancer, most patients are sporadic. That means we don't know why they got it. As I said, we routinely test everybody. A number of patients have a positive family history, but we test everybody for genetic syndromes, and a few percent have genetic syndromes. We know they're at higher risk. Lynch is the most common. It makes up about 5%. And patients with Lynch syndrome can get it very early on, and we screen those patients starting around age 20 because the risk is so high in that group of patients. Lynch syndrome, you see a lot of colorectal cancer, actually see a lot of endometrial cancer. Probably about 20% of people with uterine or endometrial cancer, women, it's associated with Lynch syndrome, but you can see ovarian, stomach, urinary tract, bladder, biliary cancer. So when we see people and identify Lynch, we routinely screen them for many, many different cancers, not just colon cancer. The best treatment options include surgery, radiation. We now have lots of drugs to treat and kill the cancers, and we have drugs that target the genetic changes, including drugs that hit the blood supply of the tumors, and immunotherapy is used, unfortunately, right now, just in a small percentage of patients with colorectal cancer, but it can be really very, very helpful. The first drug for colon cancer was 5-FU. That was designed back in 1957, and for about 40 years, it was basically our only drug. We now have, and I'll show you adjuvant treatment, chemotherapy, prevents recurrence in the patients with more advanced stages. 5-FU is also used for a number of different cancer types. We now have lots of drugs for cancer of the colon, and I was doing an inventory sort of from previous talks. We have over 20 different drugs we use, depending on the genetics of the cancer and the risks. 5-FU, other intravenous drugs. We have antibodies that attack the blood supply and different markers on the tumor. So to choose the best therapy, we need to know the extent of the tumor, which is called stage, the previous tumor, previous treatments, the markers of the tumor, normal body functions, because we may adjust it depending on how the liver and kidneys are working, and we assess the relative activity and efficacy of these. As I said, we have a number of different drugs, and these are the drugs we use are linked to the genetic changes in the tumor and the patient. The first one here, for instance, the DYPD, if somebody lacks that, then they're going to get more toxicity for the first couple drugs, and we may not use those or we may alter the dose. So we carefully choose the drugs based on the patient's genetic profile. Immunotherapy is used much more widely now. As I said, right now, it only works in a few percent of the colon cancer, but it can be remarkable in causing tumors to disappear in some of these patients without surgery even, without chemotherapy even, and without radiation. Rectal cancer in patients that have some of the appropriate genetic changes, we just give like 3 or 4 months of immunotherapy. This shows you adjuvant treatment. These patients had stage 3 colon cancer. It had spread to the lymph nodes. It was cut out, but we know those patients are at increased risk. And the bottom curve here shows the survival being about 40 or 50% out to about 8 years when they have spread. But if we gave 5-FU, we increased that survival rate by about 15% or so. And at that time, we were giving a year of chemotherapy. We now give routinely 2 drugs, and for a long time, we were giving 2 drugs for 6 months, oxaliplatin and the 5-FU. And I helped lead in this country a study that involved over 13,000 patients. We looked at the newer agents and said, well, can we get by with 3 months? So we gave half the patients 6 months, half the patients 3 months. And you can't tell there, but there are two curves there. There's the 3-month survival curve, and there's the 6-month survival curve, going out to 5 or 6 years, and you can't see them apart, and that's because it's the same. Now, for most part, we get by with three months of chemotherapy, and that saves not only the cost, but clearly toxicity, and so that's become the standard of care for most of our patients now with this cancer based on this study. I just want to mention clinical trials because, as you heard, I've been involved in hundreds of clinical trials. We're trying to improve the cancer diagnosis and treatment, and to do those, we have to study them in patients. The treatment often starts using new drugs in advanced disease. The gold standard is where half the patients get the new drug, and it may be a new drug plus an old drug or just a new drug. It's rare, but sometimes these have placebos or sugar pills, but you'll be informed of that. All the patients all know that. But most of our studies just are comparing new and older drugs or new combinations. We have studies looking at drugs to prevent cancer, and we've been involved in some of those. We look at new drug combinations like immunotherapy with chemotherapy. We have some supportive care trials, new ways to help prevent nausea and vomiting in our patients. Trials are generally divided up into phase 1. This is a brand new drug. It may have looked great in the mice, but now we're introducing it to people. Phase 2 is looking for the efficacy of these new treatments, usually either alone or in combination, and it involves dozens or hundreds of patients. And then the phase 3 is comparing the new treatment versus the older treatment. So in summary, screening has clearly been shown to decrease the risk of death from colon cancer and even decrease the incidence, because we get those polyps out before they turn to cancer. And screening is still not used in a lot of the public, and we want to encourage that. While the best screening approach is still under study, whether it's blood in the stool, DNA in the stool, colonoscopy, it's essential that you adopt one form or another of screening. And appropriate follow-up is essential for the people who have an abnormal test, because otherwise it's just going to grow and have cancer. We have an increasing array of drugs we're treating, and there are a number of standard treatments that are available for our patients with early cancer to prevent recurrence and prolong the survival of people with advanced cancer. And we have lots of clinical trials. I'm testing new drugs all the time in our patients to try to get better results and improve their survival. And at this point, I'll stop and be happy to take questions.
Thank you, Dr. Shields. For those that are online, please place your questions in the Q&A section and we will fill them. For those in the room, Vera will come around with the mic so that you can ask your question. Or is there another mic?
Well, somebody just talk. Yeah. Yes. Lynch syndrome is a genetic change in the person's DNA. It's inherited. And it's only, in colon cancer, it's only in about 5% of the patients we see. It's pretty rare. It's probably 1 in 100 in general. But when somebody walks in with colon cancer, there's a few percent chance that they have it. And we do genetic testing on everybody that walks in with colon cancer to see if they had Lynch. One, because it's important for their family to know, because we would start screening potentially at age 20. And also it modifies the drugs we get. Immunotherapy works much better there. So we test everybody for Lynch when they walk in. Endometrial cancer, they test everybody for Lynch too. It's a change in the ability of the body to repair DNA. So there are more mutations that occur that lead to cancer. They're actually working on vaccines to help prevent cancer and Lynch syndromes. There's some early studies with a couple different vaccines. So I'm hopeful in a few years we may actually have a vaccine for people with Lynch syndrome.
We have another question. I'll be right back.
At what age do you stop taking colonoscopies?
Well, that's a good question. It's always debated, and it's the same question for mammography and other things. Sometimes they'll say somebody at 75 or older. The usual I have is sort of what somebody's life expectancy is. And if somebody's got really bad heart disease or lung disease, and you think that's going to be life limiting, well, you won't do it. But if somebody's otherwise in good shape and is 75 or 80, and they're likely to live another 10 years, it's still worth getting another one at that point. But generally by 80, 75 or 80, we would stop doing it.
If we do have an online one. Are there specific biomarkers or mutations that influence prognosis or treatment?
Lots of them, and certainly we routinely test for particular genes. There's, for instance, a KRAS gene that actually alters some of the treatments we choose, but also it indicates that there's a worse prognosis. And I was just looking at an article I was involved with where we found, unfortunately, in African Americans, there was a higher incidence of KRAS mutations. And that's one of the reasons why there might be a higher death rate, in part, not the only reason. So, and then a lot of these tumors, as I said, like Lynch syndrome, we're looking for particular genetic changes, and immunotherapy may work. We have other KRAS mutations that actually we've got brand new drugs that target it that are very good. So we routinely do panels of genes in everybody that walks in the door to look for some of these things. When somebody has advanced cancer, I run a panel of 23,000 genes. We look at everything, trying to figure out, is there a target that I've got that's going to be good? And quite honestly, those genes can change over time. So if I've been treating for somebody with advanced cancer for a couple of years and the tumor's growing, I'll retest them to see if I can find something new.
Thank you for letting us know that doctors don't know everything.
You didn't know that already?
Yeah, well, that leads into my question. Because as you mentioned, in African Americans, it's very prevalent.
Yeah.
Many African Americans trust their doctors. So the trust factor is there. So it's nothing to worry about. They go home, but it is something to worry about.
Yeah.
But my question leads into yourself and the other speaker that came up said that several family members died from different and various cancers. You on your screen showed what the Lynch syndrome can connect to. Has there been any study in families that have multiple different cancers to see if the Lynch syndrome could be cause of their colon cancer, their breast cancer, their lung cancer, and some of the various other cancers?
Well, when anybody walks in the door now that I see with colon cancer, I'm always checking for Lynch every single time. That's part of the standard approach. It's the national guidelines that we always look. And that doesn't matter whether it's stage 1, that it's a super early cancer, or it's a cancer that's stage 4 and has spread. We check everybody for Lynch.
Okay, that's you. What about other doctors?
Those are that's the national guidelines. I
Okay.
can't say that every doctor follows those guidelines, but it is the national guidelines.
All right, it seems like immunotherapy options are more limited for CRC than other cancers. If that is accurate, why is that?
Well, I mean, some of it's because of the genetic changes in those tumors don't suggest that immunotherapy is going to work. We are actually working at many new drugs that are combinations of a couple immunotherapy drugs or other targeted agents. So I'm hopeful in the next few years we will see an expanding use of immunotherapy in these patients. We keep getting hints in some of the early trials. We have new antibody drugs that stimulate immunotherapy, new combinations. But the genetic changes in the cancers that we see in the colon, unfortunately, so far, it's been limited use. But we look for that option in every single patient. Unfortunately, for many, it's not really appropriate yet.
What misconceptions about colon cancer or its treatment do you commonly encounter?
I think the biggest one certainly is that, I've got blood in my stool, it's my hemorrhoids. I mean, that's clearly the biggest one. And then people should not ignore that. They should not ignore their symptoms. It's very common. I have somebody come in and they say, well, my gut has been feeling bad for 6 months, and now they finally, came in and there's evidence that it's spreading. So you do not want to ignore those symptoms or blood because you can pick up these cancers early and treat them much better. So I think that's the biggest misconception that people have.
I just wanted to know, after they have the chemotherapy, what procedures follow that? I know you said the chemotherapy sometimes gets rid of the cancer and things like that. So what's the next step? Do they have to continue on with different treatments or?
Well, in somebody with early stage cancer, stage 1, we don't even need the chemotherapy. Stage 2, it depends on some of the markers. Stage 3, most patients we end up giving chemotherapy for 3 months, as I showed you. But after that, we have a whole series of tests we do over the course of years. We do blood tests looking at various both protein and DNA markers. We do scans on a regular basis every 6 to 12 months. We do routine colonoscopies. There's a standard that, we do a colonoscopy a year after the surgery, and then we'll do another one 3 years later to look for polyps or early signs of cancer. So we have this whole sort of schedule of events that once somebody has, had their surgery, had whatever chemotherapy if they need it, we routinely follow those patients for many years to make sure it's not coming back or spreading.
Anything online?
Go ahead, she's been waiting.
There you go, Donna.
I was diagnosed with colorectal cancer 2011. I received 6 months of chemotherapy. I was given oral chemotherapy because it was 7 days on, 7 days off. When I didn't receive the infusion, I was taking the oral.
Right.
But my question is, how common is diverticulitis or losis associated with colon cancer?
Diverticulosis, which just for those of you who don't know it, is literally like an outpouching of the colon. Our diets tend to be high in refined foods, which aren't good for us for a lot of things, including getting colon cancer. But when the bowel contracts, there are little outpouchings that occur. These are what we call diverticula. Those can perforate and cause what's called diverticulitis or inflammation, which is generally treated with antibiotics. But that is not particularly a risk of colon cancer. But they're extremely common to have diverticulosis.
How can patients weigh quality of life versus treatment intensity for colorectal cancer?
Well, I mean, there are two issues there. One is in the adjuvant treatment. So somebody that's got, say, stage 3 cancer where it spread the lymph nodes, and the risk of it coming back may be 30 or 40%. And there, the treatment is just 3 months. So there is certainly a risk. It doesn't guarantee the cancer won't come back, but it improves survival by about 15%. So the question is, would you take 3 months of therapy if it was going to improve your survival by 15%? And I have some patients that say no. But most patients say, yeah, for 3 months of treatment, it's certainly worth it. And if they start, and I always tell patients, if you start the treatment, it's not tolerable, you can always stop it. I mean, we always have people sign permission, to give the treatment, but they can change their mind the following week, and that's okay. In advanced disease, the risk of dying for advanced cancer, when I first started on this business, was the average survival was about 6 months without treatment, or even with, or even with that one, we had one drug back then, the 5-FU. Now our survival is measured in years. It's usually the average survival is 3 years, but I've got people 6 and more years out. And again, I often tell patients, well, we'll start the treatment, and if you don't like it, we can modify the dose, we can modify the schedule, we can modify the drugs, and you can always change your mind and say stop. But the thing that limits people's quality of life is dying, It's like you don't have good quality of life if you die in 6 months, So we can really improve that with many of these new drugs.
Yeah, we have one last question.
I have a quick 2 questions. Can you explain the difference between colonoscopy and the sigmoid?
Sigmoid. Yeah, we don't.
And the second question is are there any organisms that are common to cancer of the gut, of the colorectum?
Okay. In terms of the sigmoidoscopy, just gets to the first part of the colon. It doesn't go all the way around. The advantage of the sigmoidoscopy is you just need a couple of quick enemas and you don't have to drink that gallon of junk to clean out your whole colon. But it doesn't do the whole colon. So I don't tend to use it very much anymore for screening or, although studies have obviously been done for it, most of the time our screening is done with a full colonoscopy. And your second one was about gut. And actually, people have been looking at the bacteria of people's guts with and without cancer, and there are alterations in the bacteria. We don't know enough to say, oh, you should take some antibiotic to prevent cancer. We haven't gotten there yet, but we certainly do see certain bacteria in some of these tumors, and we're trying to understand them and how they affect the tumor growth and behavior.
Let us take a moment to reflect on what we've learned today. We have just a few quick questions to help us think about the quick takeaways from today's session. Here, I'll put it in. For those of us joining us in person, please take a moment now to complete the green-colored sheet of paper, post-knowledge questions. One of our COE team members will be coming around to collect them. For our participants joining via Zoom, a poll will be launching on your screen in just a moment with the same 3 questions. Please take a minute to answer them using your device. Thank you for your participation. We will now read through the answers. Okay. Okay, 1, I know I have hemorrhoids and occasionally notice a small amount of blood in my stool. Because hemorrhoids can cause bleeding, I do not need to mention this to my doctor or consider evaluation such as colonoscopy. True? False? Not sure. False. Number 2, my colon cancer was removed surgically, but has spread to a few nearby lymph nodes, with appropriate treatment, which may include a course of chemotherapy. There's still a good chance the cancer will never come back. True, false? Not sure. Very good. False. True. 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 True.
Most of those people on those curves were still alive 5 and 6 years later. It still does in some patients, that's for sure. But the data shows that the surgery and potentially some chemotherapy for 3 months, most of the patients are cured. Yeah, the lymph nodes are part of the routine surgery.
Number 3, which cancer is estimated to cause the second highest number of cancer deaths overall in both women and men in the United States in 2006? Select one. Pancreatic cancer, colon cancer, colorectal cancer, lung cancer, liver, or biliary cancers. Colorectal cancer. Very good. Thank you, folks.
Okay, you have one more evaluation to complete. You have the white sheet. Please take a moment and complete that sheet. While you're completing the sheet, I will let the people online know that we're collecting all your questions, and then we will get back with you via the email and let you know your answers. Two, Dr. Shields will stick around for a little while. Right after the right after the program, so that if you have some additional questions, you can talk to him directly. What we do ask, though, is personal situations like I'm the patient, this is what happened to me, this is what my doctor did. He doesn't have anything to do with that. So, but general knowledge information is great. The other thing is that we hope that you share this information with your family and friends. We want to share good information, not myths. A lot of myths floating around out there, a lot of misinformation. Please do talk to your friends and family. And if nothing else, get them having a conversation, and they can have a conversation with their own physicians. Yes. Yes, we do. I'm going to talk about that right now. Thank you for the segue. So, all right, and so we're wrapping up our program. Thank you, first of all, so much for being such an attentive audience. Thank you so much. So before we close, we want to encourage you to go back to our vendors, visit all the tables. You see where Danielle is standing. That is where you can sign up to be more involved with us. You can become part of the COE. You can learn more about research and become an advisor to a researcher just by signing up, and we will guide you through the process. Most of the individuals here on stage, they've done it themselves. It's good for anybody. You don't have to be a rocket scientist to be involved. So, and if you're interested in research, we have our RAP. And the RAP is when you get a chance to work directly with a researcher and hear about their research and advise them on different aspects. We want to thank everyone for being here tonight, especially our moderators. They just did a great job. Vera and Kenyatta and Craig, thank you so much. You did an excellent job. And this program would be nothing without our Honorable Dr. Anthony Shields. Give him a hand. Our next event is scheduled for April 22nd. Before you leave, please stop by and register and pick up the flyers at the table. And from all of us at the Karmanos Cancer Institute, the Office of Community Outreach and Engagement, we thank you for being a part of our evening's program, and we invite you back again. Drive safely, be careful, get your screening. Take care. We have